Hey everyone, and welcome to this explainer. I'm absolutely thrilled you're here. Today, our goal is pretty simple, but incredibly important. Absolute mastery of the renal and urinary system. We're going to build your knowledge right from the ground up, starting with foundational physiology, and then advancing all the way to high-stakes clinical application. So whether you're reviewing for your boards or just trying to sharpen your clinical assessment skills, you are absolutely in the right place.
Okay, let's dive right into this. Our agenda today covers anatomy and physiology, diagnostic tests, acute and chronic pathologies, treatments and transplants, infections and structural disorders, and we'll wrap up with an NCLEX practice exam.
All right, Section 1, Anatomy and Physiology.
You know, there's a fundamental rule in medicine. We really have to thoroughly understand normal homeostasis before we can even begin to accurately identify pathology. When most of us think of the kidneys, we immediately just think of urine production, right? But they do far more than just make urine. They are literally the ultimate homeostatic regulators. They balance our acid-base levels, excrete metabolic waste and bacterial toxins, and tightly control our fluid and electrolytes. And on top of all that, they actually act as endocrine glands. They secrete renin to regulate blood pressure, erythropoietin to stimulate red blood cell production in the bone marrow, and they synthesize vitamin D so we can actually absorb calcium. A perfect example of this homeostatic control in action is the carbonic acid bicarbonate buffer ratio. The kidneys are actively managing this absolutely crucial 20-to-1 balance. So for every 1 part of carbonic acid, there must be exactly 20 parts of bicarbonate. This exact ratio is required to maintain a normal arterial blood pH of 7.35 to 7.45. If the kidneys don't maintain this, we're looking at potentially fatal shifts in the blood's acidity.
Moving right along to Section 2, Diagnostic Tests.
Now, as future clinicians, interpreting lab values accurately is arguably our most powerful assessment tool. It's essentially our window into how well all those physiological functions are actually performing in real time. And this brilliantly illustrates why understanding vital distinctions, like BUN versus serum creatinine, is just absolutely crucial. While both of these tests evaluate renal function, serum creatinine is the absolute gold standard for measuring glomerular filtration rate, or GFR. Why? Well, because BUN can easily be artificially skewed by non-renal factors, things like a high-protein diet or even just a simple fluid volume deficit. Creatinine, on the other hand, is a much more specific indicator of actual underlying renal dysfunction.
Okay, Section 3, Acute and Chronic Pathologies.
So now that we know what normal looks like and exactly how to test for it, let's look at what happens when the renal system actually breaks down. Acute kidney injury, or AKI, is the sudden, rapid loss of kidney function. To truly wrap your head around it, you kind of need to mentally map exactly where the failure is happening in the patient's body. We break these down into 3 distinct areas. Pre-renal causes occur before the kidney, usually because of ischemia or decreased blood flow. Intrarenal causes happen right inside the kidney's parenchyma itself, often from toxic substances or prolonged ischemia. And finally, post-renal causes happen after the kidney. Think of this like a literal plumbing obstruction between the kidney and the urethral meatus, something like a calculus or a tumor blocking the flow.
This systemic failure actually builds a very specific timeline of pathology. You see, AKI progresses through 4 distinct phases. It always begins with the onset of the precipitating event. Next up is the oliguric phase, where urine output drops dangerously low. We're talking less than 400 milliliters a day. And let me tell you, this phase brings lethal risks, like fluid overload, pulmonary edema, metabolic acidosis, and uremia. It is highly dangerous. Now, if the patient survives this, they'll enter the diuric phase as the kidneys slowly start to regain their function. And then finally, they'll move into the recovery phase.
Now, unlike the sudden and potentially reversible nature of AKI, chronic kidney disease, or CKD, is a slow, one-way street. It's an irreversible progression. The stages are categorized by the estimated GFR just plummeting, starting from mild all the way down to severe, where it drops to a terrifying 15 to 29 milliliters per minute. As this disease progresses, it literally affects every major body system, creating some really complex special problems, like severe hyperkalemia, metabolic acidosis, and anemia, that are going to require really intense, ongoing management.
Which brings us to Section 4, Treatments and Transplants. When the kidneys can no longer filter toxins or balance fluids on their own, we have to step in with life-saving renal replacement therapies. Hemodialysis is super common, but it comes with some incredibly severe risks, like a suspected air embolus. If a patient suddenly develops dyspnea and chest pain during dialysis, you have to execute this emergency action sequence immediately, no hesitating. First, stop the dialysis.
Second, turn the client on their left side and place them in the Trendelenburg position, so their head is lower than their feet. Third, administer oxygen. And finally, notify the healthcare provider. This specific positioning is absolutely critical because it physically traps the air embolus in the right side of the heart, preventing it from traveling straight into the lungs.
All right, Section 5, Infections and Structural Disorders. Now, what's really interesting here is how a localized issue in the urinary tract might seem super minor at first, but these plumbing issues can rapidly escalate into massive systemic crises, like urosepsis, which is a severe gram-negative bacteremia originating right there in the urinary tract. Let's take benign prostatic hypertrophy, or BPH, for example. The slow enlargement of the prostate physically compresses the urethra. Early on, this just causes a diminished size and force of the urinary stream, but later, it leads to complete urinary retention. When that obstruction gets severe enough, surgical interventions like a transurethral resection of the prostate, or TURP, are absolutely required to restore that vital urinary flow. Another incredibly painful obstruction is renal calculi, kidney stones. And treating these isn't just about managing that sharp, severe colic pain or just waiting around for them to pass. It actually requires strict, proactive dietary restrictions based entirely on the specific composition of the stone once it's retrieved. So, depending on the lab analysis, patients must drastically modify their diets. They might need to avoid high-purine foods like sardines and liver, or high-calcium foods like dairy, or even high-oxalate foods like spinach and rhubarb.
And finally, Section 6, NCLEX Practice Exam.
All right, it's time to shift our energy to some active recall. Let's challenge ourselves to apply all this knowledge we've just built to some high-stakes clinical scenarios. Question 1 is a select all that apply. Listen closely. A client with acute kidney injury has a documented serum potassium level of 7.0. Which of the following actions should the nurse plan as a priority? Should they place the client on a cardiac monitor, notify the healthcare provider, put the client on NPO status except for ice chips, review the client's medications to determine if any retain potassium, or allow an extra 500 milliliters of IV fluid to dilute the concentration? Take a few seconds to think and lock in your answer.
Okay, got it. The correct actions are place on a cardiac monitor, notify the HCP, and review medications for potassium retention. Listen, a potassium level of 7.0 is a literal, life-threatening emergency. It places that patient at immediate risk for lethal cardiac dysrhythmias. That is exactly why continuous telemetry and rapid HCP notification are absolute top priorities. And giving an extra fluid bolus, that would be highly, highly dangerous because it could cause severe fluid overload in a patient who already has acute kidney injury.
Moving on to question 2, another select all that apply. While undergoing hemodialysis, a client suddenly develops acute dyspnea, chest pain, and severe anxiety. The nurse strongly suspects an air embolism. What priority actions must be performed? Do you administer oxygen, continue dialysis at a slower rate, notify the HCP and rapid response, stop dialysis, turn the client on their left side with head lower than feet, or bolus the client with 500 milliliters of normal saline to break up that embolus? Think back to what we just covered.
So the crucial point here is knowing that emergency protocol absolutely flawlessly. The correct actions are administer oxygen, stop dialysis entirely, place them in the left side Trendelenburg position, and immediately notify the HCP and rapid response team. Under absolutely no circumstances do you ever push a fluid bolus to try and break up an air embolus, and you certainly do not continue the dialysis.
Awesome. Question 3. A client arrives at the emergency department complaining of low abdominal pain and hematuria following a physical altercation. The client is completely afebrile. The nurse should immediately assess the client for a history of which condition: acute pyelonephritis, glomerulonephritis, trauma to the bladder or abdomen, or renal cancer in the family. Look really closely for the specific clinical clues here. If you guessed trauma to the bladder or abdomen, you hit the nail on the head. The keys in this clinical picture are that the patient was in a physical altercation, they have lower abdominal pain and blood in the urine, and most importantly, they are afebrile, meaning no fever. An afebrile state following a physical fight strongly points toward physical trauma rather than an infectious process like pyelonephritis, which would almost always present with a fever. All right, our final question. During the physical assessment of a client admitted with acute kidney injury, the nurse notes the brand new development of fine crackles in the bilateral long bases. Which of the following is the most appropriate action? Document the finding as a normal expected development during the oligaric phase, Immediately notify the HCP, or encourage deep breathing exercises and reevaluate in 4 hours.
The absolutely correct action here is to immediately notify the healthcare provider. While it is true that AKI can lead to the oliguric phase, developing fine bilateral crackles is a massive red flag. It's a warning sign of fluid overload leading straight to pulmonary edema, which is a serious and potentially fatal complication. You absolutely do not just document it and move on or wait 4 hours to see what happens. You escalate it immediately. And wow, that wraps up our masterclass. Understanding the renal system is an immense, life-saving responsibility, and it relies entirely on sharp, rapid clinical assessment. So the question I want to leave you with today is, are you ready to be the clinician who catches those subtle, quiet clues before they snowball into a full-blown crisis? Keep honing those diagnostic skills, and I'll catch you in the next explainer.